Welcome to today's webinar, Promoting Mental Health Across the Lifespan in Individuals with Down Syndrome. My name is Laura Crone. I am the Project Manager for Research and Education at the Advocate Medical Group Adult Down Syndrome Center in Park Ridge, Illinois. We are a healthcare clinic for adolescents and adults with Down syndrome, ages 12 and older. Since opening in 1992, our healthcare providers have seen over 6,000 patients with Down syndrome. In addition to providing patient care, we offer a variety of research and education opportunities, such as this webinar. Our presenters today are Abby Rowley and Dr. Brian Chicoine. Abby is a licensed clinical social worker who has been in the field since 2014 and worked at the Adult Down Syndrome Center since 2022. Dr. Brian Chicoine is the medical director of our center. He co-founded our center in 1992 and has provided medical care for adults with intellectual disabilities for over 35 years. Before I turn it over to our presenters, I have a few reminders. Next slide, please. This webinar is being recorded. The link to the recording and the slides from the webinar will be emailed to attendees within 1 week. There will be time for Q&A at the end of the webinar. Please submit questions using the Q&A option in the Zoom toolbar. Lastly, please note that the information in this presentation is for educational purposes only and does not take the place of working with your own healthcare professionals. We know that an hour and a half is a long time to dedicate to a presentation, so we really appreciate you all being here today and giving us your time. With that, I am going to hand it over to Dr. Chicoine.
Thank you, Laura, and welcome everyone. I'm glad to be here with you today. So we'll jump right in. We've got a lot of material to cover. So we're going to review common characteristics of people with Down syndrome, and we think these are very important to understand with regards to promoting mental health as well as understanding mental illness. And again, these are common and not universal, and that's an important thing to consider. We want to discuss some concerns and topics at different ages, and we're going to discuss some general strategies to promote mental health, and then we're going to discuss some additional treatment approaches. We did get lots of questions regarding mental illness, this webinar is really focusing on promoting mental health, so we probably won't have time to answer the questions on mental illness, but we will share a lot of resources that are available on our website to address, and we will have future webinars on more addressing mental illness. Next slide. So really, we're here just to share some information, and I think we think it's important to understand that mental illness happens like physical illness. So each individual has an entirely unique combination of genetics and environmental influences, and we've seen this in our own lives as well as the lives of individuals with Down syndrome. You know, certainly even siblings brought up in the same household can have widely different mental health pictures, and so really there's a lot of factors that go into this, just a lot of factors that go into physical illness, upbringing, genetics, lifestyle choices, all can impact. And then we also know that sometimes, you know, mental illness can happen, you know, without a clear cause, and you know, not something someone did, someone didn't do, or whatever. You know that some of these things do occur, you know, physiologically or whatever is going on in the body and the brain. So we really do not want to take away from this that, you know, if you do all these things that we're going to talk about today, that's going to guarantee that the individual with Down syndrome is not going to have challenges, or that if the person does develop some mental health challenges, that it's because you didn't do these things. And so again, you know, there's a wide variety of reasons that these occur, and you know, we all try to do the best we can, but understanding that sometimes some challenges will occur nevertheless. So this is clearly not a commentary on parenting or caregiving or anything else like that. These are just some ideas, the things that might help improve mental health. We will our clinic is focused on adults, but oftentimes we hear that families will say, I wish I'd known this back when they were in school or when they were a young child. So we really want to share this information. It not only applies to adults, but these issues can also be looked at in children as well from a mental health promotion standpoint. This can help you prepare and plan and hopefully prevent, and then if there are challenges, to cope with some of the challenges. So again, that's what we're trying to do today: prepare, plan, prevent, and or cope. And so hopefully you'll get some valuable information on that this morning. Next slide. We think it's very important to understand some common characteristics in Down syndrome. And again, these are not universal. Some people with Down syndrome have them, some don't. They are common enough that we call them common characteristics. And these are things like the groove. And the groove is a tendency towards sameness or repetition or routine, very commonly seen in people with Down syndrome. And before I go on, part of the reason we think it's so important to understand these common characteristics or understand the potential that they're going to be there is that we have seen many, many, many people over the years that had been diagnosed with a mental illness related to having one of these common characteristics. And so in and of themselves, we do not look at these as mental illnesses. So another one is self-talk, which is a way to process and cope and analyze. So many, many people with Down syndrome talk to themselves, although subsequent studies have shown that many of us who don't have Down syndrome talk to ourselves as well. So that's certainly not unique to having Down syndrome. Concrete thinking, more black and white thinking, where abstract thinking can be a little more challenging for some individuals with Down syndrome. That's a common feature and is not a problem in and of itself, but can be a problem if it's either misinterpreted by others or situations that require less concrete thinking can be more challenging for some people with Down syndrome and sort of can be a stumbling block at times. Very strong visual memory is again not a bad thing, and this is something that's very commonly seen in individuals with Down syndrome. Almost can replay events as if they're happening in the moment. Sometimes the concept of time can be challenging for people with Down syndrome. So again, that can be a little confusing sometimes to those of us interacting with a person with Down syndrome, because the memory is so strong, but the time of when it occurred maybe not as strong, and so that can be confusing. And then what we call empathy radar, it's the ability to pick up on the emotions of others, can be a very positive thing. If someone they're with is struggling, they can pick up on that and support them. But sometimes it can be a challenge, because sometimes individuals will internalize the feelings of others. So if there's something going on in the house, and there's an upset, or there's someone ill or something, that can be, people with Down syndrome oftentimes will absorb that and then feel the stress of that. And we certainly saw that during the pandemic, where there was so much grief and change in schedules and all the other things that were occurring, and people with Down syndrome sometimes were very challenged by that. Next slide. So one of the key things when thinking about those common characteristics is, again, we really don't look at it a problem until it's a problem, and so sometimes the groove the person may have more obsessive compulsive disorder rather than just the groove, and how does that get addressed? Are the behaviors just problematic, or are they annoying to someone else? And so again, how do we address that? When is it self-talk versus hallucinations? And that can be a challenging thing to kind of sort through. Again, when is it a strong visual memory versus delusions or hallucinations? And that's important to sort through. And then again, when is, the empathy radar, can become a problem if the person is absorbing someone else's anxiety or someone else's depressed mood. And when that kind of tips over into more than just empathy, but really developing their own mental illnesses. They can be a very positive protective factor, a coping strategy, a way to deal with the world, a way to manage the world, a way to get things done. I've said many times that many of the individuals with Down syndrome we see really probably function higher than their cognitive level would suggest, because they have the groove and they're able to really do the tasks every day because they've got such strong routines. And a real important point is that the awareness of individuals with Down syndrome and their families and those supporting them is really important, because we really want to avoid misdiagnosis and misunderstandings. We really got interested in this many years ago when the clinic opened, when so many individuals we were seeing were coming into the office already on antipsychotic medications because they talked to themselves. And so again, in and of itself, we did not see this as a mental illness, but was a real beneficial thing for most of the individuals we saw. Now, certainly when there's a change, that can be a problem, or can be a sign of a problem, and so certainly deserves some assessment. Next slide. So there are a lot of issues that contribute to promoting mental health or contribute to the decline in mental health and developing mental illness. And so there's many things. Physical health conditions are so important. The brain anatomy of people with Down syndrome, whether people are physically active, that can have a very positive impact. Physical activity can have a very positive impact on mental health. Recreation and social activities, such an important piece of our mental health. Again, these are not factors that are unique to people with Down syndrome. This is true for all, but oftentimes these factors don't get considered in people with Down syndrome. Healthy eating, good sleep, stress management. Clearly, people with Down syndrome have stress in their lives, just like anyone else. It may not be the same as it is in other people, but it's there nevertheless, and important to consider as contributing to mental illness, or if the individual's sorry, I understand I'm talking a little softly, so I'm going to turn this up a little bit. So the stress management is important to promote mental health, as well as assess its possible contribution to mental illness. Simple things like good hydration, making sure we're drinking enough fluids, can have an impact on our mental health. Relationships and the impact that those can have positively or negatively in some situations. Employment and vocational opportunities, and what their implications are with regards to self-esteem and the sense of self-worth, all very important. And then, looking at social media, I mean, I think we're becoming so much more aware of the implications for everyone. And I don't think people with Down syndrome, well, I don't say I shouldn't think. I know that people with Down syndrome are not immune to the challenges that social media can have an impact on them. And then just genetics can play a role. And that's both the genetics of the family and what the mental health genetics are in the family, but also the mental health genetics that are implied with regards to the issues of having an extra chromosome. So mental illness is not a character flaw. It's a multifactorial situation, and it's something that we want to look to make sure we're considering all these possibilities if things are changing, and to consider as far as promoting mental health. So I'm going to turn it over to Abby, and she's going to describe some issues throughout the lifespan.
Thank you, Dr. Chicoine. So we'll just jump right into it because we have a lot of information to cover. So I'm going to start going through the different ages and sort of stages of the lifespan with childhood, with the consideration, though, that, some of these skills that we say, can be taught in childhood, they can really be taught throughout the entire lifespan, and we should all continue working on the things that we are going to discuss in this portion of the presentation. So starting off with emotions, we know young folks have lots of emotions. And so some issues of concern we see amongst our patients is that there is a lack of awareness of their emotional state, or that they might suppress emotions. This is something you may have noticed in your loved one or people that you know who have Down syndrome. If you ask them how they're doing, 9 times out of 10, they're going to say good, happy, great. And we see that in the office, even when they're clearly in distress, upset, sad, they'll say, I'm happy, I'm good. And so for mental health promotion, we really want to support them in being able to identify emotions and accurately express their emotions. So this starts with the idea of co-regulation, and this is something we do for all small children, that we cannot regulate ourselves until another person, a caregiver, has taught us how to regulate alongside of another person. And so this is a skill that, we all sort of naturally do with young children. And there's an understanding though that with individuals with Down syndrome, that may take longer. They may need more co-regulation before they are able to self-regulate. So they do need that extra support. We want to work on emotion identification in childhood. We can use visual supports, sometimes using like a mirror to point out to them, like, I noticed that there are tears in your eyes. To me, that suggests that you're feeling sad, and sort of getting them to sort of recognize things going on in their bodies, and how that relates to their emotional state. We really also want to teach the idea that all emotions are okay, all behaviors are not. At our clinic, we see a lot of adults, and somewhere along the way, they've sort of associated in their minds that emotions and behaviors are one and the same, and they're certainly not. And so we always remind them, you are absolutely allowed to be angry, you're absolutely allowed to be sad or frustrated, but that doesn't mean that we get to hit other people or break things or scream and use bad language. So we like to teach the separation that emotions are all okay, but behaviors are not. And again, visual supports are a great way to teach that. So that goes along with, we want to find healthy and safe, positive expressions of emotions, not to suppress the emotions. We don't want to just say, okay, you're not sad. How do we get you to happy? But when you are sad, how can you express that in a safe and a positive way? So that again comes from caregivers and peer group, right? That we want to model those positive coping skills for the individual. We hear from a lot of people that this is, again, a natural habit of caregivers or parents that when you're upset, you don't want to spread that energy to a young child. So you always say, I'm happy, I'm good, everything's fine. But then they don't get the opportunity to see how you handle various emotions. So we encourage the idea of expressing, vocalizing, and saying, yeah, mom's really frustrated that the dinner got burnt. So I'm going to take a few deep breaths and figure out a plan for how to fix it, right? So they can see that everybody has all the emotions and everybody needs to learn to work through them in a safe way. And of course, reinforcing that idea that we still love you even when you're angry. We still care about you even when you're sad. You don't have to just say you're happy all the time in order to be accepted or appreciated. So going along with that, coping skills. We see that a lot of individuals lack certain coping skills, or people with Down syndrome may have difficulty communicating their needs, which makes coping that much more challenging because they can't necessarily express what's going on with them or what they need to feel better. So some strategies are really starting with, at a basic level, learning how to handle various emotions, sort of giving them those supports and ideas that they can use from a young age that they can continue to practice. And again, for all of us, even all of us adults, these are things that we still continue to practice. We all lose our temper at times, and we have to go back to, okay, what am I going to do? How can I calm myself down? How can I use good coping skills? You may want to provide multiple ways to communicate wants and needs, depending on how verbal or how expressive your loved one with Down syndrome is. But even if they are highly verbal, sometimes in those moments of emotional upset, the brain is not able to access that language. And so having visual supports or different opportunities, gestures that they could use to express what they want or need can be helpful in learning how to cope with feelings. Distraction and avoidance. As a parent, I know that there are times when you just got to get things done. And so we got to say, all right, we're moving on, or we're going to distract you with here, here's the iPad and we got to keep moving. However, we don't want that to become the norm. So we want to be able to teach distress tolerance skills, right? So when an individual gets upset, we want to be able to sort of ride through those emotions without just sort of saying, look over here, we're going to distract you with something else. So like for young children, if a toy that they want to play with is not available, if another child is playing with it, rather than just saying, okay, well, here's another toy, let's make you feel better, letting them sit with that emotion, letting them experience frustration, disappointment, and talking through that with them. Okay, well, how can we wait? What can we do while we wait until the toy is available? Or how can we express our frustration in a safe way? We also hear from some families that avoidance is used, like, oh, we always know that when we go to this park, there's drama because the swings are always busy and he likes the swings. So we just don't go to that park anymore. Again, it's the same idea that we don't want to just avoid entire situations to try and make our loved one more comfortable. We want them to be able to learn how to manage those feelings. Another thing we see a lot is family members always well-intentioned, always coming from the best place of wanting to sort of turn the situation around. When they see their loved one with Down syndrome is upset or sad about something, we see a lot of family members sort of taking the approach of, but we're all good. You're okay. You're happy, right? We're all good, buddy. And that can be very invalidating when they're upset about something that's legitimately upsetting to them, right? And so it also creates confusion with that idea of interoception, where like, well, my muscles feel really tight, my stomach hurts, I'm crying, but mom is telling me that we're all good. So what emotion am I feeling, right? So we don't want to just turn it around and say, we're all good, everything's fine. We want to validate, yeah, you're upset. This is frustrating for you. You're really sad about this, so that they can start to learn this is how my body feels when I'm upset, and this is what I can do when I have those feelings. Another thing we talk about is the difference between calming and coping skills. And those are terms that are often used interchangeably, and sometimes they are interchangeable depending on the situation. But what we were finding with a lot of our adult patients is that they are really good at identifying calming strategies. I take my deep breaths, I drink water, I count to 10, right? Those are good ways to calm myself down. However, we were also finding that with our patients, that doesn't really solve the problem, right? It prevents you from blowing up in the moment or saying bad words or hitting someone. But if somebody does something that bothers you, just taking deep breaths doesn't really resolve the problem. So we want to be able to calm ourselves down in the moment, but then also, what am I going to do? How can I express that I don't want people to treat me that way, or that what they said or did really bothered me, and learning some additional coping skills to go along with those calming skills. And we have lots of visuals on our resource library, all free of charge, different ways that you can use visuals to support these ideas of coping skills and emotion identification. So another area of concern that we want to start addressing in childhood and then continue throughout the lifespan are those social skills and understanding boundaries. So the issues that we see are that there may be a lack of awareness of appropriate social skills or interactions or boundaries. We know many, not all, but many people with Down syndrome really do like their hugs, and they tend to be sort of touchy-feely in some ways. And so we want to be able to teach appropriate social skills and boundaries starting from when they're kids and moving upwards. We also have the concern about there's an element of vulnerability in the Down syndrome population, whether it's because they need more support from caregivers, whether with like their personal care, hygiene, and maybe because they have limited communication where they couldn't express if something is uncomfortable to them, or if someone is behaving in a way that makes them feel uncomfortable or is inappropriate. We also hear that there may not be enough opportunities for practicing social skills. So if the individual, for example, is in like a self-contained special education class with other children of different levels, they may not get the opportunity to learn what some expected behaviors are, or what they would need to know moving forward through life. So some strategies for mental health promotion are that these skills need to be explicitly taught. And this is true for all children, right? Lots of kids have questions about these sorts of things. Why do we do this? Why do I have to act this way? And so they do need to be explicitly taught. We know for people with Down syndrome, they may need additional repetition, or they may need to be taught in a more visual, concrete manner, because social skills require a lot of abstract thinking. There are a lot of gray areas when you're interacting with other people, right? Like, how come I can hug my best friend, but I can't hug this boy that I know just from the playground. So we need to sort of sometimes putting rules in place that can help make it more concrete. We also want to start from a really young age teaching about bodily autonomy and consent. And this is a little bit of a soapbox issue for me, but I think it's super important to start. So like I said, many of our loved ones with Down syndrome may really like hugs or, sort of be very comfortable touching other people or having other people give them hugs. But we want to teach that this is, that it still requires consent. They need to give their consent for other people to touch them, and they need to receive consent from other people before they go and hug or touch another person. We want to talk about personal space, what's appropriate. We know that just kids in general tend to just be more physical in their expressions, whether it's happiness, they give hugs, or anger and they hit and kick. But we want to teach the individuals with Down syndrome how to keep themselves and others safe, because unfortunately, we see adults here, and we've heard situations where they either didn't know that they could speak up for themselves when something wasn't right, whether it was another peer touched them inappropriately, God forbid, a staff member or somebody else in their life. And we want to be able to help them know what are appropriate boundaries, and so that that doesn't get confused in their mind and open up opportunities for unsafe situations. And the last one, opportunities to practice social skills with individuals of various abilities. I'm going to talk a little bit about this later in the presentation as well, but we want to make sure that, they are exposed to individuals with various levels of social skills. So whether they're maybe in like a self-contained special education class, or if they're completely included within the mainstream education, we want to make sure that we're meeting them at their level while still also teaching them the expectations. So giving them opportunity to practice. For example, if they were in a special education class where the other students are a lot less verbal than the individual, we'd want to make sure that they were getting to practice their verbal, social skills, communication skills with same age peers. And so that's something to just be aware of in the school age years. Again, we have lots of resources about personal space, different kinds of friendships, rules for conversation, all sorts of good stuff that help teach social skills. Okay, the next topic would be the Down syndrome diagnosis. So some issues of concern that we see is how having a diagnosis of Down syndrome affects an individual's self-esteem. There may be some confusion about what it even means. Is this who I am? Is this just a part of me? And sort of putting all those pieces together. We know that there is a huge spectrum of, abilities in terms of cognitive abilities, communication, social skills, right? Everything along the way among the Down syndrome population. And so we hear some people feeling like they are left out or in the middle because of where they fall along that spectrum. It's like, well, I don't fit in with other people with Down syndrome because of my certain ability levels, but I don't fit in with my general education peers because they always see me as someone who has Down syndrome. And so where do I fit? So some strategies for mental health promotion are always to support a positive self-identity, right? This is something that we always want to do with all children, of course, like, focusing on all their positive attributes. We always say it's important to make the child aware of their diagnosis of having Down syndrome. We've had some adults, some young adults come in, and when they pull into the parking lot at our clinic and see the sign, they say, wait, why am I here? This is for people who have Down syndrome, because it's never been talked about with them in their family. And so that can make it seem taboo or like it's a negative thing if they haven't heard this information about themselves. So we always say open conversations about that diagnosis from a young age are important. Identifying and highlighting strengths, of course, is an important piece for all children, but for individuals with Down syndrome as well. Discussing ways in which all people have differences or things that make them special or unique. One way that you can talk about Down syndrome and the diagnosis is to, as a family or as a group, do research together. Read books or articles, watch TV shows or webinars, or, make it a learning experience for everyone, because no one really wants to feel like, well, mom and dad are the experts. They know more about me than I know about myself, because that's not really true. And so it can become a great family activity to learn together about what does it mean to have Down syndrome, and what are the great things I can do in my life as a person with Down syndrome. We say answer questions honestly, right? Always families we know are always so well-intentioned and loving and well-meaning, but there can be times where, if an individual says like, well, why do I have Down syndrome? And families just say, because it's a gift from God and you're special and perfect. Well, that may be a parent's viewpoint, and we all feel that way about our kids. It doesn't maybe get to the root of the question of what does this mean for me? And so we can validate, we can say that, yes, having Down syndrome may mean that things are a little bit harder for you. Certain things are more challenging, or you may feel these ways. So validating those feelings and allowing them to have those feelings and ask questions and get honest answers about, you have this extra chromosome is a little bit more concrete. It's a genetic thing that some individuals really benefit from, rather than sort of just saying it's a special gift. It's important for people with Down syndrome to connect with others who have Down syndrome or intellectual disabilities. We found that especially through adulthood, some families, if their loved one with Down syndrome has a certain skill set, maybe they're able to be in general education classes, and so their peer group is only general education peers. But then when it comes to high school graduation, those peers go off to college, get jobs, and the individual with Down syndrome might still be in transition program for a few more years. They sort of don't know what to do. It feels like they, again, feel left out. So that's why it's important to connect with other people who have Down syndrome, so that they can have a peer group who has similar life experiences as they do. And of course, finding activities that they enjoy and getting them involved in, that's good for everybody's self-esteem. If they find activities that they're good at and they feel good about, then that improves self-esteem. Something that we hear a lot about is parenting and siblings, right? So some issues of concern are the idea of fairness, and learning to parent different children differently, and the division of time between siblings. We know that some people with Down syndrome have extra doctor's appointments or therapies, or just require extra time to do activities of daily life. And so parents may struggle with, how do I make things fair for my other kids? We hear some families say that they don't treat their child with Down syndrome any different than the other kids, because, you're just one of the kids. You're going to go along with everybody else. And then we hear other families say that, no, our child with Down syndrome, they get some special privileges. They don't have as many chores or responsibilities. And so we hear that the best outcomes come somewhere between those two situations, where we want to find the balance of how can we hold the individual with Down syndrome accountable and teach them responsibilities and the importance of working within a family, but also understanding that their needs may be different and they may require some extra attention or time for certain activities. So just considering fairness and the ability level, that there are always differences in personalities in amongst siblings, right? And some people really, for example, it's that idea of kind of like love languages, right? Some people really want time and attention, and they want their accomplishments to be celebrated in a big way. Other people don't. And so we have to sort of assess what each child needs and what is going to support them in the way that they need to be supported, based on their preference and their personalities. We want to always encourage positive sibling interaction. So even if it is true that as a parent or caregiver, you have to focus a certain amount of time on the individual with Down syndrome, then to sort of not put that blame on them, being like, well, your brother needs me the most and he needs my attention right now. Saying, right, when I'm done helping him get dressed, then you will have my full attention and we can do an activity that you enjoy. So we want to find ways to encourage positive sibling interactions, because we know through adulthood that positive sibling relationships are a really great. They're a really important factor as individuals get older. Fair does not always mean equal. Fair means that, like everybody gets what they need. So you may not get exactly the same amount of time with their parent, but you should get what you need. We do want people with Down syndrome to learn responsibilities and consequences, and the home environment is a good place. So we do support the idea that, they have chores or responsibilities, or there are expectations, that similar expectations to the siblings that they are held to. Maybe not exactly the same if their ability levels prevent that, but we don't want to sort of let them off the hook, because we do see that that has consequences down the line and can lead to some extra sibling rivalry or conflict. So moving right along to adolescence. Puberty and sexuality, this is one slide in our presentation that, can be its own presentation, has been its own presentation. So we'll just sort of cover the surface. But some issues of concern are puberty and the changes that come along with it, the physical, mental, emotional, behavioral changes. Some other issues are the comfort of caregivers in discussing tough topics with their loved one with Down syndrome, that maybe the caregivers themselves are not comfortable discussing certain body parts or sex or topics of that nature. And then we also want to focus on the safe and healthy expression of sexuality and sexual urges, knowing that people with Down syndrome have a lot of the same feelings, urges, thoughts that people without Down syndrome have. And so we don't want to reinforce a stereotype that they don't, and that they shouldn't be thinking these things or shouldn't be acting in this way. So some strategies are talking about the changes before they begin, what to expect, right? And we all know, everyone got some talking tos most likely, or either in school or from family members or both, about puberty or about the changes you go through in those teenage years. But also knowing that this is not a one-time conversation. It's not a one-time conversation for any individual, but particularly not for people with Down syndrome, who really get more information the more they're hearing it. Also, the information changes over time, right? The information you got as a fourth or fifth grader, you needed a little bit more as you got older into high school and beyond. That questions changed, and the topics of conversation need to sort of evolve, but it's an ongoing conversation about puberty and about sexuality and changes. We want to normalize the changes, right? That for those of us who don't have a disability or don't have Down syndrome, we often got a lot of our information from our peer group, right? Or we could see for ourselves, like, oh, my friends are going through the same changes that I am. So, okay, this is normal. Whereas for an individual with Down syndrome, depending on their peer group or how aware they are of, the things going on around them, they might not know that this is common for everyone, and that these changes are that they do happen to every single person. We want to support healthy habits by teaching skills. So again, these are skills that need to be explicitly taught. We know that for that's best practice for people in general, that we have to teach people what to do, but really for people with Down syndrome, it might sort of be the next level. So like, for example, for young women, right, we can't just say, this is how you change your pad when you have your period, right? You might need to use visual supports. Our occupational therapist even has an example that she uses with patients sometimes, where she has a pad that she's used marker to color in and sort of says, like, when your pad looks like this, it's time to change it. You might have to set up a schedule or reminders on their phone or part in their visual schedule about it's time to go to the bathroom, and bring your supplies to change it. For boys too, you might need to explicitly teach, like, what do I do if I'm in school and I become aroused, I have an erection, right? So like, what can you do? You can, you cover, or you can excuse yourself to the bathroom, and teaching good hygiene as well. The idea of privacy, that we don't walk around the bathroom with our pants off, right? We can take care of our private business in these private locations, designating those places, washing hands, how to clean yourself up, all of those things that maybe we don't consider when we say, like, well, of course, you just go to the bathroom and change your pad. what are all of the steps, and really sort of teaching all of those steps. Um, become For caregivers, becoming comfortable with having uncomfortable conversations. We do see some adults who come into our clinic who still really don't even know the anatomically correct terms for their body parts, which of course then can make medical appointments very complicated, but it also just makes it complicated for them to have conversations about how they're feeling or about things going on with them if they don't know. So we know some caregivers might not be comfortable with that, or if there, are questions that your loved one is coming to you about sexuality or gender identity and things like that. We know it's really hard for some people, for some caregivers, to sort of get on the same page and to share that information with their loved one. But we also have to come from the viewpoint of, again, people without disabilities, people without Down syndrome have various sources of information. We can ask our friends at school, we can look things up online maybe more easily, or read it in a book. But for a person with Down syndrome, depending on their ability level, they might not have the peer group or the sources of information to get these questions answered. They might not, and they might not also have the experiences for themselves to further understand things. We always want to promote health, safety, boundaries, and consent. This is going back to the childhood conversation I had, that, we've heard unfortunate incidents that have happened either in high school or in college programs, day programs, even between individuals with Down syndrome, where there was inappropriate touching or consent wasn't given and gotten, even in a romantic relationship. And so that's why it's super important to go over these topics as well, even if you're of the thinking that, oh, well, my son or my daughter, they're not interested in that, or they're not thinking that way, or I don't think people with Down syndrome would ever really go there or do that. It's still really important to have these conversations, again, to keep themselves safe and others safe. We also suggest monitoring internet use. We hear from some individuals, some issues where, again, you can find all sorts of things on the internet. And for some of our patients, without the life experience or the ability to sort of fact check or get more information from multiple sources, they stumble upon, some like pornographic material, which then to them, that becomes the definition, or that is what sexual experiences are like, or that's what I'm supposed to do, or that's how I'm supposed to act. And they don't necessarily get the reality check of, no, that's just one video you saw. That's not representative of how things are in real life. So monitoring internet use, but then also not necessarily saying that you have to cut off internet use, but just being aware of what kind of information they're consuming so that you can then open up those conversations to talk more about it. Those teenage rebellion years. So some issues of concern is that we hear from families that they want to give their loved one with Down syndrome the desired independence, but they're also worried about safety and the individual's ability levels. If their loved one's goals for themselves are not in line with their abilities, how do you manage that? We also hear frustration from caregivers or school staff that go along with new behaviors or moods. And then there are sometimes behaviors towards the parents that are very surprising or upsetting. So some strategies for mental health promotion are teenagers. This is something that we hear in the clinic a lot, where families maybe come in and are a little bit distressed. Like, he's never acted this way before, and he's giving me attitude. He's slamming the door. He's in his room. And we sort of question, well, he has an older brother. When his older brother was a teenager, did he do similar things? Or when you were a teenager, did you do similar things to your parents? So it's a normal stage of development, right? That desire for independence, for space from their caregivers is really is normal. The timeline of onset might be different for individuals with Down syndrome, right? So like, it kind of catches people off guard because maybe it happens later than they would have expected, being like, oh no, we got through the teenage years with a, no problem, but now he's 20 or 21 and we're seeing all these things. And so it can sort of, we sort of consider that still that within this phase of like this rebellious phase. We also want to remember that, like teenagers are teenagers, there is that sort of oftentimes that stereotype or that mindset that people with Down syndrome are always happy and easygoing. And we know that's not the case. They have the full range of emotions just like everybody else. And so recognizing that, yeah, they're not always going to be in a good mood. They might be a little sassy. You might get some more attitude. And we kind of have to sort of just work through it, right? It's one of those teenage things. We want to provide safe opportunities for independence. So thinking about what their ability levels are. And so, we do, for better or worse, have the technology that we have, but that can help allow you to provide safe opportunities for independence. Like if I know my child has their phone, I can drop them off at the movies. I can track their locations to know they're there. I don't have to be there. I don't have to be monitoring everything they do, but I can make sure that they're where they're supposed to be. And we can check in, we can call or text to make sure everything's good. Right. And so a lot that goes a long way. We hear from patients that like just that little bit of extra freedom or independence it's really what is desired and makes them feel really good about themselves and feel better. Picking your battles, right? So if there's something that they can have control over that's really doesn't matter in the grand scheme of things, allowing that, right? If it's the clothes they wear, maybe that's not the clothes you would have chosen for the weather or for the event, but right, we all did this, right? We all maybe chose we all made some interesting decisions in our teenage years, but that's part of how we develop, how we learn, and we want that individuals with Down syndrome to get those same experiences. We want to allow for safe, natural consequences, obviously not putting anyone in harm's way, but this is something that I hear from my patients a lot, that they're in their parents' attempts to keep them safe and help them and teach them, they're not allowing for those natural consequences to happen. And so you could say, all right, I'm picking my battles. You wear shorts and sandals in the snow. Okay, go for it. And then they may come around and see that was a problem. They may not, but also if it's not a big deal, it maybe isn't worth a battle over. So allowing for that control and power when possible. We also say that you can hold firm boundaries for non-negotiables, right? There are certain things that just are within a family are non-negotiable. We're not going to be flexible on this and give you control over something that we don't think you should have control over. However, if in your family you're noticing that you have a lot of non-negotiables, you might want to reassess what are the things that are most important or what do we really want to focus on? Because we have heard from patients that when there are a lot of rules or a lot of firm boundaries in place, that can lead to more challenging behavior, resentment towards family members. And so if there are ways to avoid that, then that's something to consider. We hear a lot about fantasy and self-talk or imaginary friends. So the issues that we hear a lot about are lack of awareness of what really is reality, that the individual with Down syndrome may spend too much time zoning out or fantasizing or engaging in that self-talk. Or when they do talk to other people, they're only talking about their fantasy. And then refusal to engage in real life activities because my fantasy world is so much more interesting than anything going on outside of it. So I'm just going to stay in my mind. So some strategies for mental health promotion, just recognizing that all of us slip into daydreams from time to time. It's totally normal. Like Dr. Chicoine mentioned at the very beginning, we all also engage in an element of self-talk to some degree, whether it's in your car or if you don't necessarily speak it out loud, but you're really sort of running it through in your head. It does happen for all of us. Now, for people with Down syndrome, we know that they have that really strong visual memory, so it can be harder to sort of break apart from that fantasy or from that self-talk. But we suggest that, again, it's not a problem until it's a problem. So fantasies, fine. Self-talk, fine. Until, it gets to the point where, oh, they're not going to school. They're not going to their programs because they're too deep in their fantasy. We want to help them by keeping clear boundaries between fantasy and reality. We know a lot of families and just sort of joke around or casually talking, being like, oh yeah, that's your boyfriend, Zac Efron. We know you're going to get married. But for the individual with Down syndrome, that can further blur those lines and make it a little bit confusing of, well, is he really my boyfriend? So you can say, yeah, we know you like Zac Efron because he's cute or because he's funny, right? But here, you're not dating. We don't really know him in real life and sort of separating between the fantasy and reality. We also say it's important to keep the individual with Down syndrome busy with activities, right? We know that the more downtime they have, the more opportunities they have to go into that fantasy world and get deeper and deeper into it. So keeping busy with activities and activities that require attention and engagement. We know a lot of our folks really like coloring or art, which is great, but coloring and art can also allow for your mind to wander back into fantasy world. So finding activities where they actually have to be alert and paying attention, talking, or engaging with others. Monitor screen time. So be aware of what they are watching, how much they are watching, because we hear a lot of self-talk that is just direct quotes from movies or TV shows that they like. And if they're re-watching something over and over and over, that might really, really make that visual memory even that much stronger, where then now they're in the movie or they're in the TV show. So monitoring what they're watching, especially if there are some themes that are not themes that you want to promote or that are problematic, like magical or fantasy or sort of aggressive behaviors. We don't want them to emulate that and act that out in real life. Then lastly, considering what their fantasy world or fantasies provide for them. So we've heard from patients that it can provide an escape. It's their opportunity to process through things. It gives them different types of social interactions. In their fantasy world, they may have more control or power. They may be accepted in different ways. I have a patient who says, in my fantasy world, people don't see me as someone who has Down syndrome. They just say, hey, look at that cute girl. And they want to talk with me and they want to hear my thoughts and opinions. So she's really driven to that fantasy world because of what that affords her. So if we know what they're getting out of their fantasy world, if they're able to communicate that in some way, we can try to look for opportunities to give them that in the real world as well. If they want more control or power, how can we give them that control in their life? If they want to be heard or if they want romantic relationships, how can we support them in meeting that need outside of fantasy world? Okay, so the topic of inclusion, I touched a little bit of this before, but some issues of concern are that they may feel left out from their same age peers if they are primarily with other individuals with Down syndrome or disabilities. They may have difficulty coping with changing relationships. This is something that we hear a lot, that, all of us throughout our lives, friends come and go. And so, but for people with Down syndrome, it can be really hard and confusing when a friend leaves their life or it no longer wants to be friends, and how it impacts their self-esteem. So some strategies for mental health promotion are, again, making friendships and connections with other people who have Down syndrome or intellectual disabilities. Preparing and setting expectations for how friendships may change over time. They may need to hear it from multiple people, multiple times, multiple different ways that, yeah, I used to have a best friend in kindergarten, but I don't see her anymore. I have a different best friend now. And learning that that's normal. That's a normal part of getting older and developing. We want to make sure they're getting regular opportunities to meet, connect, and engage with other people, right? And in different formats, right? So if they have a passion for art, being in an art class or an art group where they can meet people who have similar interests, same with Special Olympics or sports or any sort of theater, any activities you can imagine, just finding opportunities to meet and connect and having different friend groups so that maybe there is not that sort of dependence on one or two friends, having different outlets and different people that they can go to. So we're going to move right into young adulthood. So post-high school and transition, this is a time when we see a lot of patients come into our office and a lot of families with various concerns. When high school is done, transition is done. So the issues that we see are that there's been a drastic change to their schedule. The individual has fewer opportunities for movement and socialization. The individual is overwhelmed about the future and their identity as an adult because, wait, I graduated, but what do I do now? I'm still living at home maybe, or things are kind of the same, but I feel like I should be in a different place. So that can be a concern. The lack of awareness of options that some folks, by the time they're like, we're just going to get through high school and then we'll figure it out later, not recognizing that actually now that we've graduated, there are long wait lists to get into any sort of programs, or now we have a lot of downtime. What do we do at this downtime? Depending on where you live, there may not be as many options for programming, or those wait lists may be really, really long. And then the cost of programs, because we do know that some programs are pay out of pocket and it can be very expensive for families. So those the strategies, I don't know why it got cut off, but I will go through them. We want to find ways to stay busy. So even if their schedule is not full of activities or day programs or classes, we can try to make a consistent schedule. And this is something that we talked a lot about during COVID and the pandemic, when people were still staying in their houses, that you can still make a structured day even if you're largely at home during the day. So that can include things like getting up, making breakfast, getting dressed, doing your morning hygiene, exercise, chores, going for a daily walk, visiting with a neighbor, all sorts of things you can build into a schedule to fill the day so that there is not just sitting and watching TV or just sitting and, fantasizing. We don't want that to happen because that's a hard habit to break. We know that the longer the habit goes on, the harder it is to break. An example that we always give for in these presentations about behavior, about making changes, is that for yourself, do a little experiment in your kitchen, change the location of your garbage can, and see how long it takes you to remember its new location. For all of us, habits are hard to break. So we want to start them off with good habits because it's a lot easier to build on good habits than to rebuild after a bad habit has started. So we use a lot of visual supports like visual schedules, checklists, calendars that helps sort of manage the time that was previously managed in school. We also know that like movement and socialization are super, super important. And our occupational therapist talks about this a lot. Like during the school day, there's a lot of sensory input from walking, moving, getting up and out of your seat, just walk in the halls, that if you're at home and you're not doing anything, you're maybe not getting that movement and you're not getting that sensory input. So finding ways to stay active and busy. Before graduating high school, I know there's a lot going on in high school, but the school staff should be talking about what options exist after high school and what they can do to get on wait lists or get funding, or what they should know before it gets to that point so that there is less of that down period or that lull. And there are lots of different options, right? So some of our patients go to community college, some go to universities, some get jobs right out of school, day programs, a combination of recreation programs that you can sort of see what options exist and what's going to be the best fit for your loved one. We also want to promote different lifestyles or goals. We hear from our patients a lot that they just want the same life as everyone that they see around them. Well, my brother went to college, he got a job, he bought a house, and he got married. So those are my goals. That's what I'm going to do. But that's not the only way to have a successful and fulfilling life. And so we want to make sure that the individuals with Down syndrome are getting exposure to the fact that not everybody goes to college, not everybody gets married, not everybody buys a house, right? That there are different ways to live your life in a way that still feels good to you and meets your needs and your interests. And it doesn't have to be the same as the other people in your life, like your siblings. We also think that it's important to talk about with your loved one with Down syndrome, what does it mean to be an adult? What is their viewpoint of being an adult? What is your viewpoint? And how can we sort of make those two things fit? We hear there's often a discrepancy between the individual and the family with what they want, where maybe the person with Down syndrome is like, I'm going to live at home forever. And the parents are like, oh, no, 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 you're moving out, right? What does that look like? What are our goals? How can we make them fit together? These are just important things to consider. Talking about that and having conversations, and then teaching how to meet their goals. So we hear a lot from our patients that, like, for example, getting married is my goal. I want to be married. Okay, great. But husbands and wives don't just fall out of the sky and land in front of us, right? So if you want to get married, what are some steps you have to take? You have to get out of the house. You have to introduce yourself, have those social skills, meet new people. You have to learn about dating and relationships. And so I'll touch a little bit about that in the future too. Maintaining habits and skills. This goes along with the last slide of that some issues of concern in young adulthood are that there's maybe a lack of opportunity to practice skills, right? If you're not interacting with as many people, or if you're not in a classroom setting where you're learning new things, you may not practice the skills, right? Like I don't have a need to write anymore because I'm not in school. So my handwriting is going to fall off, or my math skills or my social skills. We hear that there's a lack of need to demonstrate habits and skills and limited motivation. So for example, we hear from patients like, well, when they were in high school, they were amazing at waking up every morning, eating their breakfast, getting dressed, brushing teeth, getting to the bus on time. Now that they don't have that, they lay in bed all day. And there's no reason for them to do any of these habits, these skills. Why do I have to brush my teeth? I'm not seeing anyone today. I don't need to get dressed. And there's just not a lot of motivation. So some strategies for mental health promotion are to continue to hold the individual to prior standards, right? So maybe you don't need the same 6 a.m. wake up time that they had in high school, but keeping it reasonable. Like, okay, we're going to get up at 7 or 7:30 and start our day. And we're going to get dressed every day. We're going to brush our teeth every day, whether or not we're going anywhere, whether or not you've got a big event, you're still going to be doing all of these things. Because again, when those habits fall off, it's hard to rebuild them. Creating motivation or reasons for the individual to continue demonstrating their skills. This is something that we hear can be a challenge for families because they say, well, my loved one with Down syndrome, they're an adult, so I want to treat them as an adult. I don't want to treat them like they're a kid and take away their phone or take away their tablet or make them have a bedtime. But it's also true, and this is maybe just like a different way to think about it that might help family members, is that all of us have internal and external motivation to do the things we do, right? So if there's not internal motivation, like if I didn't love my job and want to be here and help people, well, there's also the external motivation of I get a paycheck and I have to pay my bills. And so that's another reason to get up out of bed in the morning and go to work. But so for people with Down syndrome, they may not have the internal or the external, right? I don't have bills to pay. It doesn't matter to me. I don't have to cook dinner. Someone will bring me food or I'll just grab a snack. So creating motivation or reasons like, okay, well, I'm not bringing you lunch. Breakfast is at this time. If you're not here, kitchen's closed, or we don't have access to our tablets until a certain time. And I know that the mindset of like, well, that's not fair. They're treating them like a child. But again, all of us have to learn these skills for ourselves. We have to have that external motivation sometimes to demonstrate skills and habits that are healthy for us and that will help us be successful. And then encouraging the development of new positive skills so they can continue learning just because they're not in school anymore, right? We hear from patients like, well, I would love to learn how to cook, but my parents they get nervous when I'm in the kitchen. They don't want me to do. They can be lifelong learners. There can be new skills taught and learned throughout life. And that's really good, obviously, for lots of reasons, but for cognitive abilities and independent living skills. We hear a lot about comparison to peers and siblings in this age group. They want to be on the same timelines as others. Well, everyone else I went to high school with is getting married now, so I need to get married now. No. There are feelings of disappointment, sadness, anger, even jealousy. We hear like from when it's an older sibling who has Down syndrome, when their younger sibling maybe is meeting certain milestones before their older sibling, that can be like really tough to handle, and that's understandable. There's an impact on self-esteem if they're not reaching milestones that others are, that why am I the only one? Why can't I do these things that other people are doing? So some strategies for mental health promotion are helping with goal setting. Again, where to start. That's a really hard thing for a lot of our folks that you don't just get a job. There are things you have to do first before you have your dream job that you have to, apply for a job, write a resume, go on interviews, different things that they can practice that you can help support. Praising all accomplishments, right? That it's not just the big stuff like college graduation or marriages. There are lots of amazing things that can, on a day-to-day basis, get a lot of praise and recognition. Discuss different options for a fulfilling life. Like I mentioned before, that you don't have to go to college, you don't have to get married, and you can do really great things in your future. but then also validating the feelings and experiences. I think we could all relate to that, that it does not feel good if you're the only one in your family who isn't in a relationship, or the only one in your family who hasn't, gone to college or whatever sort of milestone. You can feel sad about that. That can feel disappointing. And so we don't want to diminish that and be like, yeah, but don't worry about it. That we can say, yeah, I hear you. I understand that would be really frustrating. And then it goes back to using those coping skills and working through those emotions. Individualism is really important in this young adulthood. Some issues of concerns are that when living with family, that there are different options, opinions, options, thoughts, beliefs than their family members. The individual with Down syndrome wants the ability to explore their individuality while living at home with others. The concept of independence versus safety, and then that can lead to conflicts within the home. So strategies for mental health promotion are allowing the individual with Down syndrome to try things their way, right? So we hear from families that like some conflict arises when a family member says like, or sort of implies or otherwise says that there's a right way and a wrong way to do things. Like you have to do the laundry this way. You have to cook meals this way. And the person with Down syndrome is like, well, why? Is that really true? And so allowing them to try things their own way, if it's not harmful, right, then they can have that experience. Again, assessing, like Dr. Chicoine mentioned at the beginning, if it's problematic or just different than the way you would do it or like to do it. I know that my mom would probably be horrified with the way that I do my laundry, but as an adult, it's my choice that I get to do it the way that I want to do it. And it's not a problem, right? I'm not hurting anyone. I'm not being unsafe. So it's okay for the individual to do things differently than the rest of the family would do it. You want to provide that necessary information though, right? So for things like, for example, laundry, well, if you put everything in together, some clothes might shrink, some colors might bleed together. I just want you to have that information, do with it what you will, but we want to make sure that they have the awareness of what are the potential risks of certain choices, but allowing them to make them as long as it's not dangerous. And again, experiencing those natural consequences. That's really important. We know a lot of families want to prevent issues, and so they don't let the person with Down syndrome have those natural consequences. But that's super important for learning and growth and development, to be able to make your own choice and then feel the consequences of your own choice, rather than focusing on, well, my dad's so bossy, he always tells me what to do. Oh, I made this choice and it didn't work out. Maybe dad was right. And then friendships and romantic relationships in young adulthood. So relationships change. There's often drama amongst friends. The desire for dating can create complications, and just wanting a romantic relationship, right? That they feel like this is the stage of life I'm in where I should be meeting someone to get married. And so it's super, super important in their minds. To promote mental health, we want to allow friendships to change. I know that's hard for some families because like you maybe have formed a really good friendship with peers, family members, or parents. And so it would be hard to let relationships change, but they do. And sometimes people decide that they don't want to be friends anymore, or that they only want to be sort of like distant friends rather than best friends. And so we want to allow that to happen. Teaching social skills, again, explicit teaching. We have resources about these things, about skills related to friendships, boundaries, dating. What does that look like? How do I plan a date? How do I find somebody to date? What qualities am I looking for a person that I want to date? Because we hear a lot of times that our patients are so interested in having someone to date that they haven't really actually thought about, is this person a good person? Do I enjoy spending time with them? Right? It's just that he's my boyfriend and he's going to be my boyfriend and my husband someday. So like really focusing on, what do you want? What feels good to you? And providing, again, new opportunities to meet new people, because after high school, that social circle might shrink, and then it's really hard to find somebody to date if you've already dated everybody, or if you're just not interested. So more opportunities to meet. And then older adulthood. An issue that we see is maintaining habits. So there may be a loss of interest in certain activities or habits, or a loss of functioning and mobility. So some strategies for mental health promotion are, you can work with a medical provider and sort of figure out, is this that they're losing interest in things, or is it that they're uncomfortable, maybe physically engaging in certain activities or certain habits? Like, oh, they stopped brushing their teeth. Okay, well, check with the dentist first. Maybe that there's something going on that it's painful or uncomfortable for them. And so that can help maybe clear up some of those things. But then we also know that as people get older, that their interests do change, their energy levels change, their functioning and their mobility changes. And so we want to still look for opportunities for engagement. I know some of our patients are very stubborn and maybe we'll say like, I'm not doing that anymore. I'm quitting. I'm out. I don't want to do any of those special rec activities anymore. But we can still find ways, like maybe you don't want to do Special Olympics anymore. You don't want to play basketball because that's too hard on your body. But what other special recreation activities can we play or can we engage in? Continued learning opportunities, right? We want to keep the brain active. We know that that helps stave off some other mental health or developmental concerns. So continue providing opportunities to learn. Make adjustments as necessary. So you don't have to totally eliminate activities or opportunities, but you want to be able to support them in what they are able to do. So maybe if they are no longer interested or able in cooking for themselves, well, what can you still do to participate in family meals? You don't just get to sit in your bed and have your food delivered to you. You can still come down and set the table. You can sit with the family. You can serve yourself. We want to respect that there may be changes in older adulthood, but still like holding them to some standards. And then hold expectations as their abilities allow. Slowing down, we know that we will always question, is it an ability or is it the behavior that they're just like refusing to go to things? And again, medical providers can help with that. Because slowing down is a normal part of aging. And so some families say, is this just where we're at? That, now that he's 50, that he just doesn't do these things anymore? Or is he just being stubborn and doesn't want to? And we also have to consider the caregiver's abilities to support the individual as caregivers get older or caregivers change. Can they support the individual's needs as the person with Down syndrome's needs change? So you can always look into community agencies to help with caregiving as necessary. That can be a really important thing. And we want to allow for some slowing down while not completely eliminating activities, like I said before. So maybe they don't, if overwhelming large crowds are not working for them, what are some smaller, quieter activities that they can engage in? We also want to consider about like when we are cutting back on activities or responsibilities, what is the big picture, right? So like maybe we don't need them cooking full meals anymore, but when they were in the kitchen cooking, they were using all sorts of different skills like navigating the kitchen, using utensils, pouring liquids, right? So maybe they don't need to cook a whole meal, but which of those smaller skills can we still encourage and maintain because we don't want to just eliminate opportunities for the skills that they still can demonstrate. And life changes. So we know that change is hard for people with Down syndrome, and there's a lot of unpredictability as you get older, right? With your caregivers, where you're going to live, with your own health. We hear that sometimes many changes happen all at the same time, and that can be really overwhelming and upsetting. And the individual with Down syndrome may not be open to certain changes. Like maybe you finally get them into a residential placement that you've been on a wait list for a million years, and they're like, don't want to go, not going. So some strategies for mental health promotion are to make changes one at a time when possible and prepare for changes in advance. So like getting the individual more familiar. A lot of residential placements do this where you get, visits that increase in time and length and sort of the activities that you engage in. And so you can take it in small steps to make it feel more comfortable. Provide encouragement for things that will stay the same, right? So even if you are moving to a group home, or even if you're going to have new caregivers, other things are going to stay the same. You'll still have a bedroom here at home. We'll still celebrate holidays together. We'll still take you out for dinners. What are things that will stay the same? Because when everything changes, that's upsetting and confusing, but some things will stay the same. And putting supports in place before the big changes happen. This may be related to like their living situation where, some families are, oh, they're going to stay and live with us forever until we're no longer able to care for them. But that can be really overwhelming if you've got a caregiver who's sick or no longer able to help you, and you're grieving that or processing that, and you have to move to a new house. So we say putting supports in place before changes happen can be really helpful. All right, so I am talked too long, but I will pass it back to Dr. Chicoine for this part.
Thank you, Abby, very much. So we're going to talk a little bit. Obviously, there's a lot of health promotion issues, the mental health promotion issues, and so we wanted to focus on those today. But there's just a few brief comments about some health conditions to consider. Next slide. Some of the common mental health conditions we see are depression and anxiety and obsessive compulsive disorder. And a couple of things just to think about as far as looking as we're all doing the mental health promotion, and if things are not going as well as we think, a couple of things to consider. One is how is this change impact the person's functioning or impact the family functioning? So its impact is certainly part of consideration when making a diagnosis of a mental illness. And the other issue is that sort of the diagnostic manual, the DSM-5, which is used for a long list of mental health conditions and a criteria for diagnosis. There's much of those are self-report, and we don't get a lot of the self-report in people with Down syndrome. So oftentimes it ends up being more observable behavioral change. And so there's a companion book called the DM-ID, diagnostic manual for people with intellectual disabilities. And again, a lot of the criteria, rather than self-reportive symptoms, so rather than I feel sad, the criteria might be the person is not as interested in participating in activities that they used to enjoy. So again, that's another common thing is looking if you're seeing changes that there may not be a self-report, it may be more of a behavioral change. Next slide. And then just briefly, Abby went very nicely through the mental health promotion throughout the lifespan, but just a couple things that do tend to pop up. When they do pop up, they pop up at certain ages. They become evident at certain ages. So autism is more common in people with Down syndrome, but that is typically onset in children. It is often diagnosed a little later in people with Down syndrome than kids with Down syndrome than it is in others. But typically in the non-Down syndrome population, it's symptoms that begin before age 3. But sometimes that's not really picked up on until a little later, 5, 6, even 7 in kids with Down syndrome. And then in adolescence or early adulthood, there's a condition called what we're calling now Down syndrome regression disorder. There isn't a formally accepted name, but there is an article in which there was sort of a consensus that that's what the name is going to be. And we've given presentations on this, whole presentations, and others, including Jonathan Santoro out in California. So we certainly can't do it justice here, but just knowing that a decline in skills and some very significant behavioral and mental health challenges in adolescence or early adulthood, this is one of the things to really consider. And then certainly in our older individuals, if there's behavioral and functional changes, certainly Alzheimer's disease. But that's not typically before age 40. And so those, you really want to make sure we're looking for other causes if there's anything changing. Next slide. So again, just the counseling, when someone does have some behavioral, mental health changes, counseling. And again, I think commented on it, but certainly talk therapy is something that many people with Down syndrome can do, and for years was thought that they couldn't, but certainly many people do. But there are other forms of therapy as well, behavioral therapy, music therapy, many things that individuals can use to help with their symptoms. Occupational therapy. Dr. Frank in our office does a lot of work when our folks that have had some mental health changes to help get them going again, to get them participating in life again. And then certainly in some situations, medication. And really, when do you consider different treatments? Oftentimes, we want to try the other things before we go to medications, but some conditions, really in order for the individual to respond to the other therapies, they need to have some tamping down of their symptoms with medication. So really, it'll vary from person to person. Next slide. One other thing on that comment, generally with treatment with medications, one of the rules that we and others follow is start low and go slow, meaning when the medication is started, we usually start with a lower dose and then work our way up slowly, really finding that right dose, not too much, not too little. So again, we really are focused on health promotion today. We have a lot of resources in our online resource library, and also the Down Syndrome Medical Interest Group has a lot of information on that website as well. And for if you live in an area where you don't have access to a Down syndrome clinic and your provider may be struggling, there's a project service called Project Echo through DSMIG, through Down Syndrome Medical Interest Group, where your provider can present a case of an individual with Down syndrome. He does it anonymously, meaning that he de-identifies the individual, so we don't know who that individual is. And then a panel of experts is there to support and share information with that provider, and then bring that information back home to you, or someone else with a family with Down syndrome and their loved one with Down syndrome, to help support their care locally. Next slide. And then our resource library has a lot of information. It's well over 500 articles and visuals and webinar recordings and videos and whatnot. And we have an email list if you want to get regular information sent to you, an email. Our Facebook page has a lot, every day we put something up, and most of it is about a health issue in people with Down syndrome, whether it be physical or mental health. And then Instagram is kind of a co-occurring with Facebook in sharing information on those two resources. And our mental wellness book is available online for free. Unfortunately, about a year or so after the book was published, the publisher Woodbine House went out of business. And so looked at ways to share this information, found the best way was just to put it up on our webpage for free. And it is there both in English and Spanish, but we don't have copies of the book to buy at this point. Next slide. And again, lots of, when you look at these slides, lots of articles that you can click on these links to get information about more specific topics. And our webpage does have a nice search engine if you want to also look for yourself on the webpage, the resource library. And that's it.
Had to unmute. Sorry about that. Thank you so much, Dr. Chicoine and Abby, for all that information you shared. I am going to dive right into our questions in the last few minutes here. Do you have strategies for understanding mental health of individuals who do not communicate verbally?
You want to start with that, Abby?
Sure, yeah. So we, like Dr. Chicoine sort of mentioned with diagnosing, we are looking at more observable characteristics or changes, which then also come from family members, their perception of things. So family members can be really helpful in identifying potential changes. And we, when we do our evaluation process, we talk a lot, we ask a lot of questions, and we ask the families to think really deeply. Were there any, major changes going on at the time when you saw a change in behavior or mood? And so sometimes that can be enlightening as to what's going on with the individual. Oh yeah, that's when his brother moved off to college. And so then that's sort of like a starting point of, okay, well, how, if he's not as communicative, could we, sort of guess that that's playing a major role? Is he depressed about that? Or, sort of going from there, if we have that information from the family.
Thank you.
Yeah, I would just add, we look for patterns. It's like Abby said, it's many questions, but if someone is no longer enjoying activities they previously enjoyed, we know that sometimes can be a sign of depression. So we would certainly focus on that. Or someone is getting upset easily with little things that didn't bother them before. That can be a sign of anxiety. So really, again, the observations of others are very, very important, because many of our patients cannot share this information with us verbally.
Thank you. How does mental health tie to Alzheimer's disease?
I can take that. So Alzheimer's disease is a neurological condition. Changes in the brain, damage to the cells in the brain. But there are, so it is a neurological condition, but there are a lot of mental health symptoms that come as a complication of that. Some of it depends on where the brain is being affected by the Alzheimer's disease. Some of it's the person's response to developing the disease. They appreciate that something is changing and they can't explain it, and it's frustrating. They may be frustrated with their memory impairment. So really, there's a lot of mental health changes that come along with Alzheimer's disease. Some writers, researchers suggest that everybody with Down syndrome presents with symptoms of psychological or behavioral symptom change as the first symptoms of Alzheimer's disease. I would not say that it's everyone, but I would say that it's pretty common. And certainly at some course in the Alzheimer's disease, a large percentage of individuals will have behavioral and mental health changes.
Thank you. How long do you try a strategy before trying another? And similarly, how long do you wait to see if a medication or a dose of a medication is working?
Abby, you want to start with the non-medicinal things?
Yeah, so kind of like I mentioned, that behavior change takes a really long time. So if it's a behavior that you're concerned about, or even a change in mood that you're trying to address, it can take a long time. And especially if there's a habit that's been built, if this has been going on for a really long time, it's probably going to take a really long time to see some changes. So generally we say, like, depending on the intervention, depending on the strategy you're trying, giving it, 4 to 6 weeks to see if it's having any impact. And the tricky part is, though, is like you really have to stick to it, because if, we're kind of wishy-washy with what we're trying to change or address behavior, it gets confusing, and then the individual, it might prolong how long it takes to see a change. So it does take a really long time and a lot of commitment. So sometimes that would be depending on the behavior or the family's ability to sort of address the behavior. That's sometimes when behavioral therapists or other mental health providers can sort of step in and help, because it is a lot, depending on the behavior and how long it's been in place, to sort of address.
And from a medication standpoint, it's really varies greatly on what type of medication, because each medication will kick in, so to speak, at a different rate. Depends on the individual, what the symptoms are that you're treating. So that there really is not a golden standard to that. It's just something you really just have to assess each individual and each medication individually.
Thank you. How do you know the difference between when a person is talking about something that happened in their fantasy world or in their real life?
So I think this is a concern we hear, and so we want to pay close attention to maybe sources of their fantasy world. So like if they're watching a certain TV show or movie, or reading certain books, or things going on in the school environment, we want to make sure that that's not coming directly from that. Because I've heard people say concerning things like, he touched me or whatever, and then when you do a little bit of digging, it's a direct quote from a show that they watch on a daily basis or something. So I know that some things that are repeated back, or the self-talk, can be really alarming. It helps, and like, to sometimes have a professional person get involved, because I know as family members we have those emotions that are tied into it, but we also know that people with Down syndrome can be very suggestible. So we have to be careful about when we're asking questions, being like, well, did that boy in your class, is he the one who touched you? Right? Because they might just agree with that statement when that's not really the case. So doing a little digging, doing a little research, or asking a professional for help to sort of gather more information can help you discern whether it's something that happened in real life, or if it's coming from fantasy or something they've seen.
Thank you both so much. We have run out of time and we had so many wonderful questions. As Dr. Chicoine mentioned, our resource library has many, many resources and many that cover some of the questions. We have webinars on the Groove and on self-talk. The Groove webinar distinguishes between OCD and the Groove a little bit in a little bit more detail. We had some questions about menopause. We have some visuals for individuals with Down syndrome about that. So we encourage you to check it out. And we are always working on new resources. And if you have a suggestion, please let us know. And then just one final slide, Abby. Yep, perfect. So we are able to offer these webinars free of charge through the generosity of our donors. So if you would like to support our efforts, please see our giving page, and we will be sending out these slides with the link to the recording within a week. We want to thank you so much for giving an hour and a half of your time, and we hope that you find these resources helpful.
Thanks for being with us today.